Any question before we start with the class today? Okay, I'm gonna explain a little bit the case study that you have to do this week. Okay, in that case study, give me 1 second. Okay, I'm gonna explain. You know that you have an idea how to make the case study. Okay, 1 second, please. Okay, that case study is it's a paper. Remember that that paper, when you upload, when you submit that paper, it's gonna go to the safe assign. So you have to be very careful with the plagiarism. And the rule in my class for plagiarism go in this way. Up to up to 40% is okay. Okay, because sometimes because of the reference, up to 40% is okay. If you are over 40%, then you have 10% less, 10% penalty in your grade. Over 50%, you have 20% penalty in your overall grade. Over 60%, you have 30% penalty, and if you are above over 70%, you have zero, and then your paper are gonna be submitted to the dean, okay, and the conduct committee, okay. So be careful with this. The player is my recommendation always is that you try to submit the paper by Friday, okay. You submit the paper by Friday, and I'm going to check the plagiarism in your paper. If you are over 40% and give you feedback, listen, you have this, fix the paper. I give you an opportunity to fix the paper. If by Monday you don't fix the paper, you get the penalty, or you get zero and sent to the conduct committee. Okay. So in that paper, you have all the instructions, but I'm going to explain a little bit. Okay. You have to put your name of the school, all that information is in the first page. Then second page, introduction. What is the introduction? Is the clinical case. You are going to put a clinical case. Okay. For example, 56 years old patient come to the emergency room with pain in the right upper quadrant. The pain started like a week ago. It's exacerbated when the patient eat fatty food and is released with I don't know, with medication. Okay, that's the introduction. That's the clinical case. Okay, then you have to put the physical examination, everything. Then the second bullet point of the second topic is the pathophysiology. Okay, so in the introduction, you say that this patient, according to the science symptom, most probably have this disease. Then the pathophysiology, you explain the disease. Okay, like cholelithiasis. Okay, cholelithiasis is a disease common in this, is produced by this, and then you explain the disease. Then later you put the like labs test that was done on the patient, okay? On vital signs, everything you put right there, okay? Then you put the possible treatments for the patient, okay? When you put the possible treatment for the patient, then you put the nursing intervention. What is the nursing intervention? So what do you do as a nursing? Okay, you give the medication, you provide the patient with this, you give advice the patient that don't eat this, that to avoid, some advice. Okay. Then the last one is the reference. Okay, you have to put reference always. Okay, but that's basically, overall what you have to do in the paper. Okay. The most important is that you make a case, okay? And the topic is free. You could get any topic, you could find any topic, okay? Any disease, okay, that you want to cover, you make the case, okay? Any question? Okay, you don't have any question, then let's gonna start with the class today. Okay, chapter 27. Okay, go. What's the question? Sosa. Yes, in the instruction you have the minimum amount of pages. Okay, instruction you could find it in the Blackboard, and it's also I send it in the reminding app. It's everywhere. All the instruction. Okay, and right there in the instruction you have the pages, and also all the the bullet point that you have to cover in the whole presentation, in the whole paper. Okay. Any other question? No? Okay, then let's gonna start with the class. Is chapter 27 is intrarenal. Today we are gonna be talking about renal disease, acute kidney injuries. Okay. Okay, intrarenal disorder primarily occur primarily within the kidney. Okay, intrarenal is basically inside the kidney. Okay, and we have categories like congenital, neoplastic, infection, obstructive, and glomerular disease. That those are diseases that affect the glomerulus. Okay. Now we have pain. Okay, pain in the kidney. The right terminology is nephralgia. Okay, nephralgia is right here. Nephro means kidney, algia means pain. Okay, general fail at the costovertebral angles and record as a CVA tenderness. Okay, that's how you refer to the when you have pain in the kidney. Okay, CVA tenderness. And that's the anatomy. Okay, anatomy is at what level in your body you feel the pain. Okay, and it's right there because that's the level of the kidney. Okay, a normal urinalysis finding. Okay, always when the patient have that you are suspecting that you think that the patient have kidney problem, you have to do urinalysis. Okay, and renal function. Those are the main tests that you have to do. Okay, renal function to see if the kidney is working properly. What are the renal function? Creatinine and VUN. Okay, basically, you just have to pay attention to the creatinine and VUN. Urinalysis then give you more information. Okay, urinalysis give you the a specific gravity of the urine, osmolarity of the urine, if the urine is if the urine is dark, is clear, if you have protein, you have blood, if you have white blood cells, if you have bacteria, give you a lot of information. Okay. Other diagnosis tests could be KUV. KUV means K stands for kidney, U for urethra, and B for bladder. Okay, so in that is a sonogram that you're gonna check those structure. Okay, renogram is also another image that you do. Ultrasonography is another, and CT is another image. CT is mainly when you are thinking about uh, neoplasia, okay, any cancer. And we have question number 1 right here. A patient have pain upon light palpation over the costovertebral angle. Which term should the nurse use to describe this finding? What is the exactly? Is flank pain because the costovertebral angle is measured right there in the flank, okay? In the back, okay? Always from the back. Now we have congenital abnormality. That means those are problems that you are born with those problems, okay? Renal agenesis and hypoplasia. Agenesis means that you don't develop the kidney, okay? Basically, you don't have kidney, okay? Bilateral agenesis, that means that you don't have both kidney, is not compatible with life. When you hear this in medicine, not compatible with life, means that the patient is gonna be dead, okay? So when you give birth to a patient, it's a stillborn, okay? So dead fetus, okay? If you have unilateral agenesias, then the other kidney uh, is the one that is gonna make all the function of the both kidney, okay? Hypoplasia is that it's not well developed, okay? You have some function of the kidney, okay? Cystic kidney disease is a genetically transmitted renal disorder resulting in fluid failure. Okay, the real name for this is cystic kidney disease. Let me see. It's polycystic kidney disease. Okay, polycystic kidney disease is the real name for that disease. Okay, it's not cystic kidney disease because cyst is another pathology that is not only this one that is genetic because maybe you develop a cyst because other condition. Okay, the real name for that disease is polycystic kidney disease. We have two forms. One is the autosomal recessive and the autosomal dominant. Okay, the autosomal dominant is the adult type. Okay, is common in adult people. Autosomal recessive is common in pediatric population. Okay. You see right here, autosomal recessive form, evidence at birth, you see is in the childhood, kidney enlarged, and you're gonna see that you do an image, you're gonna see that the kidney have a lot of cysts, okay, and those cysts most of the time are filled with urine, okay. Then we have the autosomal dominant type, is the adult type you develop later in life, and is dominant. Dominant, that means that that disease is gonna be expressed in every single generations. In that family, in every generation, you are gonna have patient with the disease. Okay. Normal function kidney tissues is slow reduce. Okay, and this is genetic, chromosome 16 and chromosome 4. You don't have to know this. Okay, you have to know this. I'll let you know in the review. Okay. Then clinical manifestation, decreased ability to concentrate urine. Of course, hypertension is essential. Essential. If you don't concentrate the urine, you retain fluid, and then you have hypertension. Okay. Diagnostic tech is genetic history and ultrasonography, and treatment primarily supportive. Okay, and those patients, they at one point they are gonna need renal transplant. Okay, when they reach to end-stage renal disease, the patient go to dialysis and go to the list of renal transplant. Now we have neoplasia. Neoplasia, we have benign renal neoplasia. many type of non-metastasizing. That means that they don't produce metastasis. Okay, they don't spread in the body. Okay, and the growth is really slow. Why? Because it's benign. Okay, and diagnostic always CT. That's a better image with a better resolution to see uh, the problem in the kidney. Okay, the treatment, you have to remove the kidney. This nephrectomy means remove the kidney. Okay, renal cell carcinoma. This one is malignant of the kidney. May have family patterns. That's why you always have to ask for family history when you have a patient. One of the most common risk factor is smoking. Okay, smoking right here. Also obesity, hypertension, asymptomatic until advanced. Okay, that's the problem with the kidney, that we don't have any screening test. We don't have a screening test for that neoplasia. That's why neoplasia is so bad when you don't have a screening, because when the patient start developing the symptom, it's really advanced. Okay, and those are the common symptoms. Okay, is costovertebral angle tenderness, hematuria, and palpable mass. Okay, that's the triad for that disease. Okay, and also we have a staging from 1 to 4, and the treatment is remove the kidney. Nephroblastoma, another name is Wilms tumors, is the most common kidney cancer in children. Okay, is common in children. Clinical manifestation identified by palpable abdominal mass is the same: abdominal pain, hypertension, and hematuria. Okay, especially painless hematuria. Okay, treatment: nephrectomy, radiation therapy, and chemotherapy. Excellent cure rates. The best way to describe that is that the outcome is good. Okay. Now we have infections. In infection, we have normal protective mechanisms against infection is the acidity of the pH, presence of urea in the urine. Main, we have bacteriostatic prostatic secretions. In women, we have the glands in the distal urethra secrete mucus. Micturition is essential. That's why we have to go to the bathroom. Okay, always. Micturition is pee, normal pee. Okay, that's the description. Unidirectional urine flow. Unidirectional urine flow is because we have sometimes some anatomical abnormality that they may like reflux. Reflux, that means that the urine go back, and that produce chronic infections. Infection of the kidney is pyelonephritis, most common ascending infection from the lower urinary tract. Let me see. This most effective preventive measurement: early removal of the catheter. Okay, you put, that's called basically plastic. Okay, because it's a plastic catheter, is a plastic. If you put a plastic in a patient, remove as soon as possible to avoid infection, because plastic produce infection, and more important, they produce complicated infections. Okay, complicated UTIs always. Acute pyelonephritis, remember, okay, infection in the urinary tract system. Okay, in the UTIs, what is called UTIs, urinary tract infections, we have three names. Okay, one is urethritis, is infection of the urethra. If that infection keep going up, when you go up to the through the urethra, you get to the bladder. If you have infection in the bladder, then it's cystitis. Then if the infection keep going up, reach to the kidney, and it's pyelonephritis. So the three type of infection is urethritis, cystitis, and pyelonephritis. Okay. Major risk factor is pregnancy. Why? Because pregnancy, they produce ecstasis of the urine, and that's why they are more at risk to develop infection. Okay. Clinical manifestation: this fever with costovertebral angle tenderness, being pyelonephritis. Okay, fever caused vertebral angular tenderness, pyelonephritis is basically always, okay, is the most classic sign. Another pathognomonic for acute pyelonephritis is white blood cell gas. Okay, it's a finding you see right here. This white blood cell gas is a finding in the urinalysis. Okay, acute pyelonephritis, urosexes or organisms in the bloodstream originated from the UTI. Diagnosis presence of white blood cell gas. The treatment is antibiotic. Okay. The most common pathogen that produce in UTIs, E. coli. Why? Because E. coli is a normal flora in the urinary tract system. Okay. And we have question number 2. It's a common finding in the urinalysis of a person with acute pyelonephritis. Exactly. White blood cell gas. Exactly. Perfect. Perfect. Thank you. Pyelonephritis. Okay. Chronic pyelonephritis can result in chronic kidney disease, usually associated with reflux or obstructions process leading to presence of urinary ectasis, that means retention of urine. Okay, chronic inflammation causes scarring and loss of functional nephrons. Okay, nephron, remember that is the functional unit of the kidney. Clinical manifestation of pyelonephritis may be present with abdominal flank pain, fever, malaise, anorexia. Diagnosis, renal imaging. Okay, you have to do an image to see the problem. Okay, the treatment, correct the underlying process. If you have any obstruction, if you have any other problem, you have to correct it. You have any anatomic anomaly, you have to do the surgery to correct the problem. Okay. Conditions that interfere with the flow of urine may be congenital or acquired. Change result from location and degree of obstructions, and duration and timing. Obstructive process cause urine ectasis, predisposed to infection. Okay, common cause stones. Okay, that's the most common one. Tumor, because tumor produce obstruction and then lead to ectasis, and ectasis lead to infection. Prostatic hypertrophy, in reality, the real terminology, hyperplasia, also produce ectasis. Okay, remember that if you remember from anatomy, we have the bladder, and right there in main, of course, we are talking about main. Right there after the exit of the bladder, we have the prostate. If you have dilation of the prostate, they may obstruction of the urethra, and that produce urine ectasis. Strictures of the urethra or ureter or urethra. Stricture are also some obstruction in those part of the urinary system that also produce urine ectasis. Okay. Complete obstruction result in hydronephrosis, decreased glomerular filtration rate, ischemic kidney damage, acute tubular necrosis, and chronic kidney disease. Acute tubular necrosis is the most common intrarenal acute renal failure. Okay. Renal calculi, the real terminology is nephrolithiasis, nephrokidney lithiasis stone. Okay. Crystal aggregate composed of organic and inorganic material located within the urinary tract, also called renal stones. Urinary supersaturation, essential required for stone formation. Stones tend to form in urinary tract, and so on. Okay. Most stone composed by calcium crystal, that's the main composition of the kidney stone, but also we have from uric acid, patients that have, for example, gout, that they have higher level of uric acid, they are at risk to uric acid stone. Okay, a Struve is a huge kidney stone that needs surgery and is produced most of the time by a bacteria, and it's really common in female. Okay, Proteus mirabilis is a common bacteria that produce stropite. Cystic stones, those the cystic stone most of the time is due to genetic condition. Okay, problem with the uh, this I don't remember right now, but it's problem with genetic condition. Okay, stationary stones usually asymptomatic. Stone migrate cause intense renal colic, pain, abrupt in onset, and may radiate. Nausea and vomiting, diaphoresis is common. Hematuria, you also could see hematuria because when the stone pass through the urethra, they damage the membrane and produce a little bit of blood. Okay, and the common description of kidney when you have a kidney stone, the pain is that the pain start like, for example, in the lower quadrant and go to the pelvis, lower quadrant and go to the pelvis, and then you know that is most probably is a kidney stone. Renal calculus, most stone passes spontaneously. Diagnostic, you have to do the CT scans. The main treatment is fluid. Okay, that's the main treatment. Unless the stone is really big, and then you have to do another procedure like lithotripsy or open surgery. And we have question number 3. Which person is most prone to develop nephrolithiasis? Exactly, dehydration because you when you are dehydrated, that means that you concentrate the fluid in your body. Okay, when you are dehydrated, you increase the osmolarity in your body. That means the small particles in your fluid is higher, and that can produce precipitation of those solid material and produce the stone, also called glomerular disorder, also called glomerulopathies. Altered glomerular capillary structure and function, damage mediated by immune or inflammatory process, hereditary and environmental factor implicated. Okay, metabolic, infection, hemodynamic, toxic, genetic, or other injuries. Classification, we have primary and secondary. Primary, only the kidneys involved. Secondary, they involve other part of your body. Okay, like good pasture, systemic lupus erythematosus that produce a lot of signs and symptoms, and diabetes nephropathy. Okay, this is another classification. That classification gives most of the time the name of the disease. Okay, we have diffuse, we have focal, we have disease that is focal segmental glomerulonephritis, global, we have segmental, we have membranous, we have a disease that is membranous proliferative glomerulonephritis. Site of deposition, that means that the deposition of some kind substance in your body is the one that gives the problem in the kidney. Okay, it could be in the mesangial, in the subendothelial, or subepithelial. Okay, may result in some combination of hematuria, proteinuria, and a normal gas. Okay, let me see. Type based on protein nephrotic syndrome. Okay, listen. Glomerular disorders are divided in these two main groups. Okay, nephrotic and nephritic. Okay, the main difference is that nephrotic syndrome have massive proteinuria. That means you have more than 3.5 grams in 24 hours. More than 3.5 grams of protein in 24 hours. That means massive proteinuria. Okay, nephro o with proteinuria. Okay. Also, those patients have hypertension, could have hematuria, and so on. Okay, so in nephritic syndrome, what is the most common sign and symptom? Hematuria and also they have increased BUN and creatinine. Okay, that is called azotemia. Okay, azotemia. That's common in nephritic syndrome. So, patients with nephritic syndrome have proteinuria, of course, but it's microscopic proteinuria. That means that the proteinuria is less than 3.5 grams in 24 hours. Okay, masses proteinuria, nephrotic. Glomerulonephritis, immune response to variety of potential trigger. Let me see if we have a better slide. Acute glomerulonephritis, immune response, inflammation result in lysosomal degradation of the basement membrane. That's a special. Glomerular filtration may fall as a result of concentration on mesangial cell. Okay, because the problem is right here in the mesangial cell. Acute glomerulonephritis, clinical manifestations, we have proteinuria, oliguria, azotemia. Azotemia means that the BUN and creatinine are elevated, okay? Edema and hypertension. Treatment support this, okay? And let me see if we have, okay, this is one type of glomerulonephritis, okay? It's post-infections acute glomerulonephritis, okay? The real name is post-streptococcal glomerulonephritis, okay? Post-streptococcal, why? Because it's after infection with streptococcal bacteria, okay? One of the most common is impetigo. Impetigo is an infection and is common in childhood, okay? Also, this condition is common in childhood, okay? That you don't see this in adulthood. And the history is that the patient is gonna come, and when you ask any disease in the last month, the patient is gonna, yeah, my baby have like impetigo 2 weeks ago, okay, 1 week ago, and then most of the time you develop post-streptococcal glomerulonephritis after the second week, okay, after the first week, sorry, okay, after 7 to 10 days, okay. And the treatment, you don't do anything, okay? Once the infection go away, the problem in the kidney is gonna go away. Now we have immunoglobulin A nephropathy, another name is Berger disease. This condition is extremely similar to the first one, okay? Most of the time is due to upper respiratory and gastrointestinal viral infection, but that takes place 1 to 2 days after the infection. So you develop the infection today, and 2 days later, then you have the most common symptom is hematuria, okay? The patient is going to develop hematuria 2 days later, okay? And also we have some lab to differentiate that in this, you have C3 complement is low because C3 complement is accumulating the mesangial and is the one that produces the problem in the kidney. In this one, the C3 complement is normal, okay? Goodpasture syndrome is autosomal disorder combination of glomerulonephritis with alveolar hemorrhage, antiglomerular basement membrane antibody. Okay, those patients are gonna have hematuria, blood in the urine, and hemoptysis. Okay, they are gonna vomit blood also. Okay. Chronic glomerulonephritis assumes a progressive course, ultimately developing into an end-stage renal disease, sclerosis, and fibrosis of the kidney, present with persistent proteinuria, with or without hematuria, and a slow decline renal function. Dialysis of kidney transplant is necessary. Crescentic glomerulonephritis used to be called rapid progressive glomerulonephritis, that's the real name. Lesion and crescent shape, that's one type of lesion. They have like two types of lesion. Okay? One is the crescent shape lesions cause complication of acute or subacute infection, or multi-system disease, drug exposure, okay, acute onset with hematuria, proteinuria, and red cell cast, followed by a swift decline in renal function within the 6 months. Nephrotic syndrome. In nephrotic syndrome occurs because of increased glomerular permeability to proteins. Okay, remember that those patients have massive proteinuria, they lost the proteins. That's why another symptom of those patients is generalized edema. Okay, you lost the protein, you lost the oncotic pressure, and the fluid is out of the blood vessel, and then that produces edema. Okay. Also, those patients have hyperlipidemia and hypercoagulability. Okay, why? Because they lost the antithrombin 3. Okay, they lost antithrombin 3. Nephrotic syndrome treatment, conservative symptom management, lipid-lowering agents, steroids, antihypertensives. One of the main treatment always in those problems is steroids. Okay. Minimal chain disease. Minimal chain disease is a nephrotic syndrome. It's the most common nephrotic syndrome in childhood. Okay. Minimal chain disease. Okay. And we finish right here with the chapter. Any question from this chapter? Okay, you don't have any question. Let's go to the next chapter. Okay, next chapter is chapter 27, and right here we're going to be talking about acute kidney injury and chronic kidney disease. Okay, acute kidney injury, also called acute kidney failure, known as AKI, okay, broad spectrum of kidney disease, ranging from minor change in renal function to complete renal failure, okay, require renal replacement therapy, that is renal transplant. Sudden reduction of the kidney function causing disruption in fluid, then you're gonna have problem in the electrolyte, acid and base, okay, decreased glomerular filtration rate, retention of nitrogenous waste product. When you retain nitrogenous waste product, then you increase BUN and creatinine, okay. And we have the rifle classification system. The rifle classification: R is rate of injury, I injury, F failure, L loss of function, and E is the end stage kidney disease. Okay. Etiology and pathophysiology: a broad reduction in renal function, producing an accumulation of waste material in your blood. Okay, BUN and creatinine. That's why when the patient reach to the end stage renal disease, they have to go to dialysis, because those products produce a lot of problem in your body, and you have to get rid of those waste material. Okay. Etiology and pathophysiology: three sites of disruptions. We have the renal perfusion, pre-renal, urine flow distal to the kidney, post-renal, and circumstance with the kidney. Okay, inside the kidney, problem inside the kidney. Okay, in the glomerular and in the interstitium that is intrinsic. Okay. Oh, now pre-renal injury. Pre-renal injury is because of conditions that diminish perfusion. Perfusion means that you decrease the amount of blood that is reaching the kidney. That is what that one means, decreased perfusion. Okay. What are the conditions that decrease perfusion? All those conditions. Okay. Hypovolemia, hypotension, renal failure. Remember that in renal failure you activate the RAS. Okay. Diarrhea, vomiting, hemorrhage. Okay, it's not right here, but you have hemorrhage, then you have decreased perfusion, because hemorrhage leads to hypovolemia. Okay. Pre-renal kidney injury characterized by a low glomerular filtration, oliguria, high urine specific gravity and osmolarity, okay, and alteration in the renal function. Okay, what is the renal function? BUN and creatinine. Okay, both has to be elevated. Okay, let's keep going. Post-renal kidney injury. Okay, pre-renal is hemorrhage. There is no perfusion. Post-renal injury is obstruction, always obstruction, any obstruction. Okay, what are the obstructions? Uh, could be a kidney stone that produces obstruction, BPH that produces benign prostatic hyperplasia that produces obstruction, neoplasia that produces obstruction. Anything that produces an obstruction after the kidney is post-renal. Okay. Intrinsic or intrarenal kidney injury is problem inside the kidney, okay, especially in the Bowman calcium, in the glomerulus, okay, and one of the most common conditions is acute tubular necrosis, right here, acute tubular necrosis, okay. Two pathophysiology process, vascular and tubular. Vascular renal blood flow decrease, hypoxemia, vasoconstriction. Tubular, we have inflammation and reperfusion injury, cause gas, obstruction. And we have question number 1. A patient developed kidney dysfunction from hemorrhage. Which type of kidney injury will be documented on the chart? Who knows the answer? Okay, the only thing that you have to know right here is hemorrhage. Hemorrhage. If you have hemorrhage, that means that you are losing blood. If you are losing blood, you become hypovolemic. If you are hypovolemic, that means that the volume in your body decrease. That means that the fluid that is reaching the kidney decrease. That means that you decrease perfusion to the kidney. Then that is pre-renal, okay, pre-renal injury right here. That's the answer. Acute kidney injury. Clinical presentation of acute kidney injury divided into 3 phases. Okay, we have prodromal, oliguria, and post-oliguria. Okay, clinical presentation varies with the phases. Okay, laboratory finding can help differentiate pre-renal from intrinsic intrarenal kidney injury. In the prodromal phase, we have normal or decline urine output. Serum, BUN, and creatinine begin to raise, start increasing. Okay, insult to the kidney has occurred, and the duration of this phase will vary depending on cause of the injury, amount of toxic, and duration and severity of hypotension. Oliguria phase, that means that the urine output is decreased. Okay, you see, urine output is decreased, characterized by oliguria and progressive uremia. Uremia is waste product is increased because you don't have filtration. Okay, you decrease glomerular filtration, you accumulate urea. Okay, hypervolemia. Okay, and typically lasts from 1 to 2 weeks. Okay, and we have question number 2. A patient has acute tubular necrosis and is in the oliguria phase. Which laboratory finding is a greatest concern to the nurse? Okay. What is the answer? Okay, the answer, no, the answer is this one, hyperkalemia. Okay, hyperkalemia. Okay, you have to remember, in the oliguria phase, the patient is not peeing, the urine output is decreased, the patient have hyperkalemia. Okay, hyperkalemia is special. Why? Because hyperkalemia can lead a heart problem. Okay, when you have a patient with hyperkalemia, the first test is an EKG. Acute kidney injury, post-oliguria phase, termination of the oliguria phase. That means the patient start increasing the urine output. Sadly, not all recover. Sometimes the patient don't recover. Urine volume increase. Okay, and may last 1 week. Okay, fully recovery when the creatinine and BUN. Remember that these are the renal function tests. When you have a problem in the kidney, those two are always increased, and that's how you measure the progression of the patient. When those two normalize, the patient recover. Okay, most of the time. Outcome progressive and irrevocable loss of functional nephrons. Progressive process of chronic kidney disease. So you start with acute kidney injury. If the patient, suddenly don't recover, they can go to chronic kidney injury. Okay, and chronic kidney injury could end up in end-stage renal disease. Okay, and you have right here. Hold on, this is important. A global health problem often linked with other comorbidities, primary hypertension and diabetes. Those are the two comorbidities that most commonly produce chronic kidney injury. Okay. Okay, defines as decreased kidney function or kidney damage of 3 month duration based on blood tests, urinalysis, and image study. Okay, also defined as, okay, this is the real definition of kidney injury. Okay, because what you measure to classify the chronic kidney injury is glomerular filtration rate. Okay, risk factor, we have diabetes, hypertension. Hypertension is number one, not number two. Okay. Recurring pyelonephritis, glomerulonephritis, polycystic kidney disease, and so on. Progressive and irreversible. Glomerular filtration reduce occur with nephron loss. Kidney compensate until 75 to 80% of nephron are damaged functional. Okay, there is a theory. I don't know the real name is the intact nephron. I think that's the name. Intact nephron theory is that's why you could survive with only one kidney, okay? Because if you have two kidneys, one and the other kidney, one kidney have 1 million of nephron and the other one have 1 million nephron. We have in average like 2 million of nephron, okay? This one is 50% and this one is 50%. If you remove this one, your capacity is not reduced by 50%. Your capacity is reduced by 20 to 25 because this one is gonna compensate basically half of the function of this kidney, okay? And it's called the intact nephron theory. Now we have a stage of chronic kidney disease, progression monitored by an staging systems, 5 stages, and is due to the glomerular filtration rate. Okay, you see right here, stage 1, 2, 3, 4, and 5. Okay, what is important right here is in stage 1 and 2, you minimize risk factors, so you try to avoid to treat the hypertension, the diabetes, or any risk factor that can produce that is producing problem in this patient. Okay, in stage 3, symptoms may starting to appear and the treatment may be needed. So at this time, you start treating not the comorbidity of the patient, but the problem in the kidney. Okay, and in stage 4, then you prepare the patient for dialysis. What is the preparation? You do fistula. Okay, you do a fistula, it's a vascular surgery that you do in the patient to prepare for dialysis, okay? And then you start And also you start looking for transplant. What means looking for transplant? You have to do all the tests in the patient to look for com compatibility, okay? Somebody that is compatible that could give the kidney to that patient, okay? Now we have complication of chronic kidney disease, hypertension, or cardiovascular disease, hypervolemia. Hypervolemia, remember, if you decrease the glomerular filtration rate, you are not producing urine, then you retain fluid in your body. Uremic syndrome is due to accumulation of waste products and metabolic acidosis. Electrolyte imbalance, retain potassium, phosphorus, and magnesium, bone and mineral disorder, elevated phosphorus and PTH, okay, malnutrition, decreased intake for uremic syndrome, uh, depressions, dietary limitations, and so on. Anemia, of course, you have kidney problem. Remember that in the kidney we have the erythropoietin. If you don't produce the erythropoietin, then you decrease the production of red blood cell, and that leads to anemia. Okay. Pain and depression is not only in kidney problem. Any chronic condition can lead to depression, and you have to treat depression. Why? Because depression is extremely linked with suicide. Okay, that's why you have to treat the depression in patient. Now we have question number 3. A patient with a diagnosis of chronic renal disease has an increase in metabolic waste, pruritus, and impaired healing and dermatitis. Which syndrome is the patient experiencing? Okay, the patient is experiencing this uremic, okay, because uremic stage that produce pruritus, that is a lot of itching, impaired healing, and dermatitis. Dermatitis because the itching lead to dermatitis. Now we have preventions, acute kidney injury, early identification of risk, maintenance of fluid volume. Those patients have to drink water. Okay? Avoid and monitor nephrotoxic chemicals. Of course, those patients, if you are gonna do MRI or CT, you have to do some type of prophylaxis in those patients to avoid the damage from the contrast. Okay, the contrast that is used in those images damage the kidney. Okay? See, remove catheter. You have to remove the catheter. You have a patient that for any reason go to surgery and is in a catheter. Next day, start removing the catheter. Okay. Preventions, avoid constant media. That's what I already explained. You have to avoid constant media. If by any reason you can avoid because it's extremely necessary that you do the MRI, you have to give fluid, okay? Before and after. Before, especially before they go to the contrast media, you give fluid, and that prevent damage to the kidney, okay? Chronic kidney disease complex require multidisciplinary approach and slowing the progressing of chronic kidney disease is focus of intervention until stage 4 or 5. We have chronic kidney disease, primary fallacy, we have appropriate management of AKA, blood glucose control in diabetes, ACE inhibitor or angiotensin II blocker to reduce proteinuria. Those are basically the best medication that we could use in patients with kidney problem and also in diabetic patients. Okay, remember that diabetes lead to kidney problem. So you have a patient with that have diabetes and hypertension, you put in those medications. Chronic kidney disease, hypertension, cardiovascular disease. Cardiovascular disease is both a risk factor for chronic kidney and accelerate progression. That's the goal of the blood pressure, the medication, ACE inhibitor and ARDS. Okay, and also those patients has to be in statins. Okay, statins. Okay, it's controversial, but you have to put the patient statins. Okay? Metabolic acidosis. In chronic kidney disease, the patient have mild acidosis. Okay, and chronic metabolic acidosis is when the pH is less than 7.3. Chronic kidney disease, fluid and electrolyte imbalance, fluid restriction, if sodium is less than 135. If edema, heart failure, also you have to make restriction of sodium. Okay? Mild hyperkalemia and potassium level. You have to check the potassium level. Okay? Always remember that potassium leads to heart problem. Chronic kidney disease, bones and mineral disorder. Remember that the PTH, when you increase the PTH, you increase calcium, and calcium is getting from the bone, then you weak the bones, okay, and then that produces problem in the bones, okay. Also, patients have problem with vitamin D, okay, because remember that is also related with the kidney and the PTH. Chronic kidney disease, malnutrition, calories, vitamin and calcium increases, sufficient carbohydrates. Those patients they need a good nutrition. Okay. Anemia, if you have patient with kidney problems, then the patient develop anemia. The treatment is erythropoietin. Okay, you have to give erythropoietin. The only thing that you have to monitor is the blood pressure because the most common side effect of erythropoietin is hypertension, but it's the treatment of choice for those patients. And pain, always not only in kidney problem, in any chronic condition, you have to manage the pain. Okay? And the pharmacology is choice of medication, and those need to be considered. Patient age, comorbidity, degree of kidney failure. You have to be very careful with the medication because most of the medication are excreted, eliminated by the kidney. So any drug that is eliminated by the kidney, you have to avoid in those patients because then you produce toxicity in the patient. Okay? And depression, of course, you have patients with that chronic condition and they start having signs and symptoms of depressions. You have to put in medication. Okay? You have to give medication to treat the depression, okay, to avoid suicide. Okay? Dialysis, remember, once the patient reached to stage 5, the patient has to go to dialysis, okay? And we have different type of dialysis. We have hemodialysis, that's the regular one. The patient go to the hospital. Peritoneal dialysis is another is a type of dialysis through the peritoneum, through the belly, okay? That you could do it at home. The patient have a training, and then the doctor send all the equipment and everything the patient needed, and they do it at home. Chronic kidney disease, hemodialysis, artificial kidney. Hemodialysis is basically because the glomerular filtration rate in those patients is so low that the kidney are not filtering anything. Then you put it in a machine, that machine is basically a kidney, okay? And it's gonna do what the kidney should be doing, okay? And it's most of the time 3 times a week, 4 hours. It's a lot of time. It's really sad for those patients that are in dialysis. Peritoneal, is through the belly, and nowadays the patient could do it at home. Okay. Transplantation. Okay. Once the patient get to stage 5 that the patient is in dialysis, then the patient is in the renal transplant list. Okay. Unfortunately, they have to wait until they find the match, some kidney that match that patient, unless in the family there is somebody that match that patient, then you get it from the family. And also getting from the family sometimes is a problem. Don't think that is so easy like that. Chronic kidney disease in older adult, majority of patients diagnosed with chronic kidney disease are older, most of the time. Uh, they are over 80 years old. Dialysis for elderly is becoming worldwide. A comorbidity condition of this population require complex care because they have a lot of comorbidity. Okay, comorbidity. If you don't know, comorbidity is basically the chronic pathology that the patient have, okay, like hypertension, diabetes. Okay, any question from this chapter? No questions. Okay, if you don't have any question, let's jump to the last chapter. I know this class is long, but we have to cover all the chapter. Okay. Now we have disorder of the lower urinary tract. Okay. Lower urinary tract responsible for the transport, storage, and elimination of urine from the body. A structure we have the ureters, collect urine and transport to bladder. A bladder that we store the urine. Urethra is the connection from the bladder to the outside. Okay. And associated urinary sphincter. Remember that in that whole system we have sphincters. Okay. Micturition is voiding, is peeing, is urination. Okay. The real medical terminology is micturition. Okay. Right here, micturition. Okay, involve both reflex and voluntary mechanisms. Okay, because in the urinary system we have voluntary and involuntary structures. Okay, type of disorder we have voided dysfunctions, congenital, neoplastic, infection, inflammatory, and obstructive. Role is to transport urine formed by the kidney and allow to remove that urine. Okay. That's basically the function of the lower urinary system. Okay. Physiology of micturition. Pontine micturition center coordinate relaxation of the internal sphincter and contraction of the bladder to enable urination. Okay. Cerebral cortex primarily inhibit the process through conscious control of the external sphincter. Okay. The external sphincter is somatic innervation. Internal sphincter are visceral innervation. Okay. Bladder innervating is supplied by the sympathetic nerves, allow relaxation and feeling. Okay. Stimulation of parasympathetic nerves from S2 to S4 result in bladder contraction and relaxation of the internal sphincter to initiate bladder emptying. Okay? So basically, the bladder, when the bladder start feeling, they reach to one point that they send signal to the brain, and the brain send signal back to the bladder to make contraction of the bladder. Okay, at the same time that you make contraction of the bladder, you make relaxation of the internal sphincter. sphincter to allow the urine go, through the urinary system. And that's when you feel the sensation that you have to go to the bathroom, okay? Because the only one that you can control like uh, voluntary is the external sphincter, okay? Using internal sphincter, bladder is prevented from emptying until the pressure in the body of the bladder rises above the specific threshold. Threshold is when you send the signal, okay? That hello, the bladder is full, we have to release this, okay? And then we have external sphincter, uh, allow voluntary emptying of the bladder, okay? Mechanism of micturition, voiding, coordinate nerve response, allow to the dorsal muscle to contract and both urethral sphincter relax. Okay, the dorsal muscle is in the bladder. Okay, continent individual is able to coordinate urination at a suitable location and desired time. Okay, residual urines. Normally, adult bladder contain less than 50 to 100. That's extremely important because when you study urinary incontinence, you have to know those values. Micturition requires central autonomy and peripheral nervous system function, of course, everything. Diagnosis test, urinalysis for diagnosis of infection. Okay? Ultrasonography to visualize any anatomical abnormality or any other type of abnormality in the urinary system. Okay, fluoroscopy voiding also does is to check if the urethra doesn't have any problem. Okay, urodynamic test does a test to diagnose voiding dysfunction like urinary incontinence. And we have question number 1. Which information is correct regarding the lower urinary tract? Who knows the answer? Exactly. Answer is A. Remember, you have to know those values. When the bladder is empty, those are the normal volume of the bladder, okay? Maybe second, lower urinary tract symptom and syndrome, okay? Maybe secondary to disorder of the lower urinary tract. Pathologies affect the central autonomy and peripheral nervous system. Now we have incontinence. Incontinence is when you can hold the urine. Okay, that's basically what means incontinence. Okay, you can hold the urine. We have stress urinary incontinence. One of the main characteristics of stress urinary incontinence is that the patient, when they cough, when they sneeze, they leakage a little bit of urine. Okay, another way is that when you increase intra-abdominal pressure, because when you cough and when you sneeze, what happens is that you increase the intra-abdominal pressure, and that may pressure in the bladder, and then you leakage a little bit of urine. Okay, that's basically maybe because of obesity, okay, childbearing trauma, cystocele. Cystocele is basically like it's basically it's a cyst in the urethra, okay, in the bladder that push the urethra, and then that's why the patient have incontinence. Urgent urinary incontinence, okay, urgency, okay, urgency, that means that you are urged to go to the bathroom, okay. So one of the main characteristics of those patients and how they are going to present to the hospital is that they can reach the bathroom. They feel they need go to the bathroom, but they can reach to the bathroom. Okay, on the way going to the bathroom, they pee themselves. Okay, and is a problem in the overactive detrusor muscle. Okay, in this one is overactive detrusor muscle because for some reason the detrusor muscle may spontaneous contraction, and that spontaneous contraction squeeze the bladder, and then you need to go to the bathroom. Okay, so in this case, urinary urgent urinary incontinence is overactive overactive detrusor muscle. Okay, in the stress incontinence is uh, overreactive urethra. It's not right here, but it's overreactive urethra. Okay. Okay, let's keep going. Let me see. Now we have incontinence, overactive bladder syndrome, urgencies is associated with increased daytime frequency and nocturia. Also, we have mixed incontinence. Mixed incontinence is that you have both. Okay, the patient when they cough and sneeze, they pass a little bit of urine, and also they feel they need to go to the bathroom and they can reach to the bathroom. It's a mix of both. Also, we have another type of incontinence. Okay, this one, overflow incontinence. Okay, overflow incontinence and neurogenic bladder is basically the same. Overflow incontinence is a patient that they don't feel the need to go to the bathroom and they leakage a little bit of urine. Okay, so they leakage a little bit of urine and they don't feel anything. They are sitting, oh my God, look at this. And basically they pee themselves. Okay. So how do you differentiate this from the other two? Because when you check the bladder in those patients, the bladder is always full. Okay. Remember that normally after you go to a bathroom, the bladder is like 50 to 100 milliliters. Okay. In those patients, after they go to a bathroom, the bladder is gonna be like 800, okay, 700, because it's full. They can't empty the bladder. That's why it's overflow, and it's neurogenic because they don't feel it. For some reason, is this condition is common in patients with diabetes, okay, and patients with neurological problems. Why? Because the communication between the bladder and the brain have some obstructions. Okay, so the bladder can send the signal to the brain that the bladder is full. Okay, so to make the trousers muscle contraction, they can send that signal, and what happens is that the bladder get full, and when they can't hold any more urine, they leakage a little bit. Incontinence, functional incontinence related to physical or environmental limitation result in inability to access toilet in time. Transient incontinence, sudden onset as a result of potential reversible conditions such as infection, constipation, or fecal impactation. Diagnostic, basically the first thing that you do is bladder diary. Bladder diary is that the patient has to record how many times they go to the bathroom, how many times they go in the at night. They have to record the daily on how they go to the bathroom in a daily day. Okay, and then from there, you put the patient in treatment. Okay, also you could do a diagnostic test. Okay, and treatment most of the time is life change. If the patient overweight, they have to lose a little bit of weight, reduce caffeine intake. Caffeine intake because caffeine produces relaxation of the smooth muscle and maybe produce urinary incontinence or facilitate the urinary incontinence. Okay, and sometimes we use drugs. Okay, some medication, pelvic floor muscle training. Okay, those are the Kegel exercise. Kegel. I don't know the right pronunciation. It's like Kegel exercise. Okay, bladder training is bladder timing. Okay, it's also, for example, the patient that have urgent incontinence, you give light timing. Okay, you say to the patient, you have to do on a schedule. Every 2 hours, you have to go to a bathroom. Okay, and sometimes also you use medication like anticholinergic and alpha adrenergic blocker. Estrogen, sometimes you use estrogen and it's common in a postmenopausal woman. Okay, estrogen most of the time is used in postmenopausal woman. Enuresis is intermittent incontinence while asleep. Okay, that's common in children. Okay, and you start thinking enuresis is the patient. Let me see if we have it right here. Okay, type of enuresis. Okay, listen, I'm gonna explain. Enuresis is that the baby is peeing in the bed at night. Okay, that's what it means enuresis. Okay, and that half a time. Okay, if the patient is 7 years old and still peeing at night, then you start thinking in that pathology. Okay, so before 7 years old is normal. Unless the patient have, because we have primary and secondary enuresis. Okay, primary enuresis is that they never have a dry period. Okay, they were like peeing at night their whole life until 7 years old. If the patient have, for example, they stop peeing at 3 years old and they go back at 4 years old, that's secondary. Then you start thinking enuresis. So you skip that 7 years old in the secondary. Okay, the treatment is this is the main treatment, vasopressin. Okay, the main treatment is, first of all, is education with the patient. Okay, you as a dad has to wake up 3 in the morning and put the patient in the bathroom. If that doesn't work, then you put an alarm. An alarm is something that you put in the bed when if they pee the bed, the alarm is gonna fire, and then the patient, is to give education to the patient. And if all the natural way fail, then you use the vasopressin. Okay, and if that one failed, then you have to do further investigation. You have to do urinalysis, image to the kidney to see if there is any anatomical abnormality, okay, or any other condition. Physical examination, you see right there, you have to do all that. If the patient, the treatment, behavioral modification, education, okay, enuresis alarm, medication, presence. That's the only one, okay. That's the only one medication. Imipramine, we don't use that anymore. No. Okay, desmopressin is basically the only one. Overactive bladder syndrome. Okay, overactive bladder syndrome increase urinary urgency, a decreased frequency. Okay, related to involuntary dorsal muscle contraction, hypersensitivity of afferent nerve, or abnormal processing in the CNLS of the afferent signal from the bladder, associated with aging, female gender, diabetes, constipation, fecal incontinence, diagnosed by history, physical exam, and urinalysis. Okay, overactive bladder. Treatment is behavioral therapy, voiding schedule. Okay? Remember, the overactive bladder is the urgent incontinence. Okay, in the urgent incontinence, you have to do the voiding schedule, pelvic floor, muscle training. That's the Kegel exercise. Okay. Interstitial cystitis, bladder pain syndromes, chronic condition consisting of bladder pain, urgency, frequency, and nocturia. Diagnosed based on symptoms. A small number of persons will have hernia ulcers. Treatment identify contributory lifestyle factors such as some food and beverage. Avoidance is primary intervention. Medication may be helpful in relieving symptoms. Vesicular reflux, that's sometimes due to anatomical problem, and is that the urine go back to the urinary bladder, okay, and go back to the kidney, and that produce recurring UTI infection, okay, recurring UTI infection, and uh, you have to do an image. You have to do an image to see the problem. We have question number 2. A patient have vesicular urethral reflux. Upon review of the history, which finding will the nurse typically find? Okay, and the answer is this one. Exactly, recurrent. You see, you have urinary reflux, you're gonna have recurrent urinary tract infection, recurrent UTI. Now we have congenital disorder, obstruction of the uretero-pelvic junctions, blockage in urine flow, partial or complete, from the renal pelvic at the entry point of one or both ureter. May be congenital or acquired. Pathogenesis, stenosis. Stenosis means narrowing of the ureter. Okay, typical present with hydronephrosis. Why hydronephrosis? You have stenosis of the ureter. All the urine is gonna go back to the kidney. Okay, and then in the kidney they are gonna form the cyst. Okay, cyst full of urine around the kidney, and that's hydronephrosis. May be managed conventionally, renal ultrasound, or require surgical intervention. Urethral ectopic, that means the urethra is not in the right place. Okay, that means ectopic. When you hear ectopic, that means it's not in the right place of your body. Okay, single urethra implanted in an abnormal location or a duplicated urethra can increase risk of infection and reduce renal function, typically found with other genitourinary pathology, and they require surgery. Urethrocoel is cystic dilation of the distal end of the ureter. Okay, typically at type we have intravesical or orthotopic urethrocoel. We have extravesical, we have single system and duplex system. Urethrocoel is obstruction in the collecting system result in urethral and renal calyx dilation, reflux, and infection. Clinical manifestations include hydronephrosis, again UTIs, and other problems. Okay. Urethrocoel surgical intervention is necessary. Of course, you have to do a surgery to fix the problem. And the goal is to control infection and preventing all the complications. Okay. Bladder cancer is the fifth most common cancer. Risk increase with age. Predisposing factor include smoking. Okay, that's the main risk factor. Also, some um, occupational exposure. Okay, that is one type of occupational exposure. But the most important is smoking. Primary manifests as painless hematuria. Okay, uh, painless hematuria. That's how you differentiate bladder cancer from kidney cancer, because basically the presentation is the same. Okay, kidney cancer is painful. The patient is gonna have pain with hematuria. Okay, painful because have costovertebral angle tenderness, and hematuria. That is called painful hematuria. So if you see a patient that doesn't have costovertebral angle tenderness and have hematuria, that is painless hematuria, then you start thinking bladder cancer. Also with history of smoking, bladder cancer. Cystoscopy is the diagnostic test you have to do as an image. Okay? Urethritis, inflammation of the urethra caused by infection from the bladder. STD is sexual transmitted disease. Okay, that's one of the most common produce urethritis, STD, especially gonorrhea. Cystitis, of course, is inflammation of the bladder. Okay, and is most of the time ascending infection. Okay? Manifestation for cystitis or any UTI, most of the time the manifestation, the sign and symptoms are the same. Okay, they have frequency, urgency, dysuria, suprapubic pain. Okay, cystitis, most female patients treated based on symptoms. Male children, complicated case may require urine culture and further assessment. Okay, because UTIs in male most of the time is a complicated UTIs. Okay, UTIs are divided in uncomplicated and complicated UTIs. Okay, and that division is due to the treatment. Okay, because uncomplicated UTIs 3-day treatment, complicated UTI 5-day treatments or 7-day treatments. Okay, so that's the main, and the difference is by the piece. I have to do this piece. Okay, the piece. Okay, what are the piece? Is like plastic that you have the cat penis that you are a male. Okay, those are one of the piece. You have to do antibiotic and symptoms studies in elderly. We have question number 3. An 83 years old patient is confused, anxious, lethargy, and has no appetite. Which of the following condition may be responsible? Okay, the most common is cystitis, UTIs. Okay, the most common infection that produce all that confusion, anxious, lethargy. The most of the time the patient develop what is called delirium is due to infections, especially UTIs. Lower urinary tract urolithiasis, stone forming anywhere in the urinary tract, may often caused by a stone traveling to the urethra, bladder, may originate in the bladder or the urethra, manifestations associated with tissue irritation and obstruction. Urolithiasis, similar to nephrolithiasis in terms of risk factor and stone, is basically the same. Okay, infection present, treated with appropriate antimicrobial based on culture and sensitivity tests. For stones that do not pass spontaneously endoscopic lithotripsy, that's a procedure. Ureterolithiasis, usually those that were able to pass through the junction of the renal pelvis and the urethra. Manifestation include urethral colic, hematuria, tachycardia, tachycardia, diaphoresis, and nausea and vomiting. Treatment with alpha-adrenergic blocker. Okay? That's when you see a female with BPH medication, because alpha-adrenergic blocker is a BPH medication. That's why you hear, a female that is in BPH medication, don't think that the patient is doing something wrong because that's normal and it's due to uh, a stone in the urinary tract. Okay, calculi because of a stone traveling from the urethra, and manifestations is hesitancy, frequency, and dysuria. Basically, those are the manifestations of UTI. Okay? Is infection, of course, the patient has a stem infection like fever, you have to give anti bacteria. Okay, right here you have a clinical case. That clinical case is for you to study. Finish right here.